and an almost good afternoon. My name is Salar Ahmed, and I am a medical student at the Aga Khan University Hospital and a member of the Student Organizing Committee at 3NOS. It is my distinct honor and privilege to welcome you all to the third session, Adult Neuro-Oncology. I'd like to start by introducing the chair and the co-chair for the session, Dr. Iram and Dr. Sahrish. It's a pleasure to have you both with us. Dr. Iram Bukhari is a neurosurgeon, currently working as the Associate Professor of Department of Neurosurgery at Jinnah Postgraduate Medical Center, Karachi. She's a Fellow of College of Surgeons and Physicians, Pakistan, and the Fellow of American College of Surgeons. Dr. Iram, I'd like and request you to please take your seat. Now to the Vice Chair. Dr. Sahrish Abrar completed her medical degree from Sindh Medical College and went on to complete her training in radiation oncology. She is currently affiliated with the Aga Khan University Hospital, and her interests lie in brain, gynae, breast, lower GI, radiation therapy. Dr. Sahrish, I would request you to please take your seat. And so with this, I'd like to hand over the session to our esteemed judges and the chair and co-chair. We wish you all an incredible learning experience ahead. Thank you.
Good afternoon, everyone. Thank you, Salar, for a kind introduction. I welcome all the participants in the session, and I welcome our esteemed guest. So our first speaker is Dr. Jinsong Wu. Jinsong Wu is a professor in the Glioma Surgery Division, Neurosurgery Department of Hoshan Hospital, Shanghai Medical College, Fudan University, Shanghai. He developed a novel integrated technical system for a multimodal brain mapping strategies and established a Chinese language cortical distribution atlas. He has been awarded distinctions by the Congress of Neurological Surgeons, the Journal of Neuro-Oncology, the Shanghai government, and the Chinese Neurosurgical Association. Today, he will be presenting on artificial intelligence neuropathologist for brain tumor identification. I welcome you, Dr. Wu. Over to you.
So today's topic is about the artificial intelligence neuropathologist for brain tumor identification. So this is an R&D project in cooperation with two Chinese companies, including United Imaging Intelligence and Zhongji Biotechnology. So, as we know, pathological examination is the final judgment among all medical examinations. So it is known as the gold standard of diagnosis. However, pathological diagnosis is correct or not is directly related to the subjective experience of pathologists. So it is difficult to train a pathologist as a subspecialist, requiring a long period of time to build a personal experience. Moreover, the incidence of CNS tumor itself is not like common cancers. So the amount of pathological diagnosis of CNS tumor is not sufficient in the pathological department of some general hospitals, which also limits the training of neuropathologists. Besides, the process of pathological diagnosis takes time. Finally, there might be inconsistency between different pathologists. The process of tumor diagnosis includes 1, collecting tissue samples by surgical treatment, 2, staining glass slides, 3, observe the histological variants such as mitosis, cell density, and other characteristics under the microscope. 4, to complete classification and grading. That's the traditional pathological diagnosis workflow. With the rapid development of artificial intelligence, especially image processing, we now have the chance to apply it to assist pathological diagnosis. Firstly, we have to digitize pathological images. Secondly, we use deep learning to achieve AI-engaged pathological analysis. Part 1 of our study is glioma subtyping. First of all, we need digitalization. We developed a simple scanner, which is based on the standard microscope, attached with a micromotion platform, goes in S shape to take photos of the slides by using the camera above. There are 300 patch images in total, and each individual patch has 30% overlap with surrounding ones for image stitching. It takes 12 minutes to get such large restricted area of view. Our data is from Huashan Hospital CNS Tumor Biobank. We collected 5 subtypes of glioma, 323 cases, 97,000 patches in total, and separated to training, validation, and testing sets. All patch images are manually labeled by pathologists. Back then, our study was based on WHO 2016 CNS tumor classification. The glioma subtypes we included was oligodendroма glioma 2, anaplastic oligodendroma grade 3, astrocytoma grade 2, anaplastic astrocytoma grade 3, and glioblastoma grade 4. Step 1, we classify on patch level and use 3 deep learning models. First is DenseNet. It is a basic structure algorithm for image classification. Second is SEBlock. It is a multi-ternal feature extractor. Third is weighted cross-entropy loss. It is used to fix the imbalanced data set. Step 2 is slide level diagnosis, which used a data-driven decision tree to combine patch level results. We can see different colors representing different subtypes. It helps us intuitively observe patch results. In this case, blue represents an anaplastic oligodendroma. In the individual testing set, our results show that patch level accuracy of 83.5% and slide level accuracy of 87.5%. It takes 5 minutes to run each case. Based on 5 histological subtypes of glioma, we simply add another network of molecular information. This decision tree can classify cases into 13 subtypes by entering IDH and 1p19q status. The outcome is published on Neuro-Oncology in 2020. There are still possible improvements for the above study. First is to obtain other types of brain tumor. Second is to consider how to reduce manual labeling. Third is to work on whole slide image. Also, we need to reduce the time consuming. Finally, we are going to stick with the new guide of WHO CNS5. So we have our part 2 work, extend to more brain tumors. Now we digitize our slides by using digital slide scanner, so we can get whole slide image. During the process, the camera can rapidly capture patch images under 200 magnification. The system can provide autofocus, stitching, correction, and storage. Whole slide image collection will produce around 1,000 patches regarding the size of stain area. The digitalization process takes around 5 minutes. In this part, we extend the categories of different brain tumors. Other than the 5 subtypes of glioma, we mainly added metastasis, CNS lymphoma, ependymoma, and non-tumor to our study, all in regarding to the WHO CNS5. This time, although we still need manual labeling, but the work amount was seriously reduced. We labeled by area other than patch. Also, we can use weekly supervised partial label. While only small amount of data was manually labeled, the remaining images were automatically labeled by algorithm. We used 1,038 slides in total, and they are randomly assigned to training, validation, and testing groups. We use 3 steps processing to perform classification of 9 types of brain tumor. First, patch level will separate 6 tumor types based on the cell morphology: astrocytoma, oligodendroglioma, metastasis, lymphoma, or ependymoma, and non-tumor. Second, the high-risk evaluation will locate high-risk feature markers for mitosis, necrosis, macrovascular proliferation to state the grade 2 to 4 of astrocytoma and oligodendroglioma. Third, by performing multi-instance learning, we combine the above steps to complete slide level diagnosis. In step 1, patch level classification, the basic model is like part 1 of our study. The difference of the tumor is the tumor cell types are now 6. By testing on 13,426 patch images, the patch level accuracy remains at 85%. And you can see those extract numbers of accuracy on the right. Step 2 is to locate high-risk markers. In our case, it's basically macrovascular proliferation and necrosis. It is designed to let artificial intelligence learn the histological feature of high-grade tumors. We can achieve it by a few manual labeling. According to the heat map, we can see that the attention network can accurately locate the features. The model will determine whether it is a high or low risk cases. It is evaluated by using 13,572 patches of individual testing set. We reached accuracy of 97% and with 88% sensitivity. Step 3 of our model is the overall feature extractor by combining cell type and high-risk markers and input them as a multiple instance. It runs through feature embedding, instance pooling, and multi-head attention. Finally, we will get slide level diagnosis. For slide level diagnosis, the average accuracy achieved 93%. The time consuming to run each case is around 5 minutes. For slide level diagnosis, the average accuracy achieves 93%. The time consuming to run each case is around 7 minutes. In summary, one of our automatic digitalization, second is auto-stitching to provide whole slide images. Then our system can classify and grade 9 types of brain tumors and locate high-risk areas. Also, we provide auto storage of all images. We are able to maintain accuracy with increasing images and more classifications. Part 2 manuscript and the patent are in preparation. We got NMPA certificate. That means the Chinese CFDA for medical device class 2 for this outcome. And we appreciate the cooperation with United Imaging Intelligence and Zhongji Biotechnology. As we compare part 1 and part 2 study, you can see 1, the expansion of tumor types. 2, the field of view is now whole slide image. 3, different label strategy. 4, WHO CNS 5 updated. 5, weekly supervised learning. Finally, the time is reduced to less than 10 minutes. Now we are moving to the part 3, the future work of our study. First is the high input scanning, so the image collection can run more, further reduce the workload of pathologists. Second, automated learning, as so can be known as self-updating. It can be achieved by pathologists' correction during everyday use. Finally, we need to include rare tumor types and explore how to train the model with very few cases. That's all for our study. So thank you very much for your attention and the patience for any inconvenience of the connection. Thank you.
Thank you so much, Dr. Wu, for this interesting talk on artificial intelligence and deep learning. So nowadays, artificial intelligence is everywhere, and the studies you showed, it's like it is going to take up the job of many of pathologists. So thank you again. Our next esteemed presenter is Dr. James Balogan. Dr. James Balogan completed his basic neurosurgical training at the University College Hospital, Ibadan, and proceeded to the University of Toronto, Canada for his clinical fellowship in surgical neuro-oncology, skull-based at the Toronto Western Hospital, Toronto, and pediatric neurosurgery at the Hospital for Sick Kids. His clinical and research focus is on the epidemiology, science, and surgery of adults and pediatric brain tumors. He will be speaking on conflicting challenges of a surgical neuro-oncologist in LMIC. I welcome you, Dr. Balogan. Over to you.
All right, thank you very much. I hope everyone can hear me.
Yes, clearly.
All right, thank you. Appreciate it. So I want to thank Professor Enam and the host of all of the very great people who have been supportive of his work in personal for this invitation this one. It's morning here, here in Nigeria too. We're just about 4 hours behind Pakistan. So I want to thank you for this on the conflicting challenges of a surgical neuro-oncologist in sub-Saharan Africa. Perhaps this is in what two folds. One is possibly to encourage people who are practicing in LMICs with respect to overcoming the challenges that we all commonly share. And the second fold perhaps is to also encourage those who support what we do in LMICs. So I hope that some people, one can take one or two things away from this presentation. So I have no disclosures with respect to this presentation. I practice in sub-Saharan Africa. Basically, this is Nigeria, where I practice. We do have a population of 200 million now by recent estimation, a projection that is meant to double by 2050. Obviously, one of the issues at stake here is the fact that the head allocation from the national budget annually is really way below par. It's about 3 to 6% in the last couple of years. And most importantly, most of the population, which is what I would think that you also experienced in Pakistan, mostly most of LMICs, including Sub-Saharan Africa, most patients still have to pay for their healthcare out of their pocket. So this is the hospital where I practice, the University College Hospital in Nigeria. It's about 900 to 950 bedded hospital. It's been established since 1962. So, and neurosurgery, perhaps neurosciences kind of reside in this center. So basically, in order to kind of put things in a little perspective, obviously, we do know that from recent findings, there's no really difference in terms of tumors that are found whether in HICs or in LMICs. And we did quite a quick scoping review last year, published in Neuro-Oncology, just to find out what kind of spectrum of tumors had been reported from Sub-Saharan Africa. And you can see this is not much different from what you will get, aside the fact that obviously in HICs, you would have gliomas predominating mostly and metastases as one of the most common brain tumors. And so just to again put things in perspective, and I'm sure that everyone in the room and everyone joining in who practice in LMICs know almost all of those challenges where patients would present late to the clinician, and obviously these would increase the risk of morbidity as well as mortality. Like I said, most patients will pay from out of pocket. There's limited, even when you do have patients undergo surgery, how much of pathology facilities do you have and support? And in terms of that, even when you want to then do research, what uphills do you face? Way back in 2013, you could see what would constitute the neuro-oncology workforce, because again, neuro-oncology is a multi-specialty kind of dimension. And you see that way back in 2013, there were 39 neurosurgeons. So you could imagine what the challenges were. But obviously, if you look down on this slide, there are now 120 neurosurgeons in 2022. For 200 million people, you would appreciate what the burden is. Obviously, for all the other subspecialties, neurologists, neuropathologists, even the radiation oncologists, there has been some increase, but the question is whether that increase do tally with the numbers that we have in terms of population. Obviously, in order to understand what exactly is the problem in terms of when you look at research output from Sub-Saharan Africa in terms of neuro-oncology, we then found that we needed to have more numbers and quality in terms of brain tumor research. And obviously, most articles, most publications from this end were not PubMed indexed, so it kind of limits their visibility internationally. We do find that most people, even when they do the research, is mostly what you can call clinical case series, essentially lacking basic science and even population-based researches. So we do understand that in the last couple of years, there has been some remarkable shift in neuro-oncology. It doesn't matter what domain you are in, whether you are medical or whether you're surgical or radiation, there has been some really big shifts in neuro-oncology from the biomarkers. And now from the 2016 WHO classification, we now have evolved into the 2021 WHO classification. And obviously, the jury is out, especially with respect to practice in LMICs, whether all of this classification further increase the disparity that we have in terms of access to neuro-oncology care or not. But my own position has always been the fact that science moves things forward, and all of what science is trying to do is to improve outcomes of our patients. So whatever we have to do, we need to do it. We cannot just complain about what is happening. And obviously on the surgical aspects, there has been some also remarkable shift, as you can see, the surgical agents have improved neural navigation, fluorescence surgery, just to be able to detect what's the residual tumor. Obviously, changing things in terms of the nomenclature and in terms of diagnosis, the DNA methylation. Obviously, that even then hasn't been truly incorporated into the 2021 WHO classification. Obviously, now there's a shift towards liquid biopsy where you could actually get some DNA of from the bloodstream and try to kind of make a diagnosis of tumors and perhaps say exactly what kind of tumors you're dealing with. So again, this is just a 2021. It's a milestone, but it's challenging for us in the LMICs. And now when you decide that you want to do neuro-oncology in LMIC, I used to tell myself, this is probably the most important slide for me, because when you decide that you want to do LMIC, what's going to be your personal motivation? Again, you have to keep yourself motivated when you do the focus and you place your life to do certain things about what's going to keep you motivated. You're going to have to take up the responsibility to kind of measure up to international standard. Again, with all of the challenges that you face as a clinician, whether medical or surgical, the question is, how do you do that? When you go for conferences and people are presenting very basic sciences, all kinds of ground shifting researches, and all you have to do is to perhaps present the epidemiology of what you have. It's a big question, and it's the conflict of trying to stay relevant without saying that you're coming from a resource challenged environment every time you kind of interact with your colleagues. Again, what's going to be, how you're going to determine strict dedication to neuro-oncology, just like one of, and you see most people from LMICs, you have interest in quite a lot of things. It's not just neuro-oncology because again, perhaps it's difficult to just focus on that. So the question is, do we then stay paralyzed with all of these challenges, with all of what we face? What do we do? I like to just refer to what is the last one. He says, Michael Jordan says, obstacles don't have to stop you. If you run into a wall, don't turn around and give up. Figure out and how to climb it, go through it, or walk around it. And I dare say that sometimes you may have to really blow the obstacle off. So what are we trying to do here? Basically for us, it's a really limitation. And of course, when you look at other LMICs, apart from patients presenting late, some of the things is also the fact that there are religious undertones to it. There are cultural issues, and there's always this belief that brain surgery is fatalistic. And in order just to challenge these, we decided to take on this issue and see how we progress with it. We with two patients where we admitted patients in the morning and had brain surgery. One was for metastasis, the other was for low-grade glioma. And we operated in the morning, and these patients were discharged in the evening. Obviously, this kind of changed the attitude of people around, including the healthcare workers who partook in the care of these patients with respect to this brain surgery being safe, even in our environment, and to be able to do it on outpatient was really intriguing for most people around. So kind of trying to break down all the prejudices that people have. We need to continue to see how much we can adapt the things that are not just being done in HICs, but things that are becoming standard of care. Obviously, I put in this slide again to elicit that you got to keep pushing, you got to keep doing what you have to do. In a case like this, when you have tumors, basically, which appears like a GBM. I mean, it was a GBM, you could see some necrotic center. It was kind of limiting and restricting on DWI. And we thought that these tumors straddling the postcentral gyrus, and you could see on the other side is the motor cortex. So you can see that on this side, whether it's pushing it forward, or it actually resident there. And we decided just to be able to map the anterior and medial part of this tumor, and you could see the outcome here, gross total tumor resection. And what really was important for this gentleman, who was a 71-year-old retired physician, was the fact that he needed to have good quality of life, even when he's going to face, even when he's going to have chemo radiation. And so these are important things. And you could imagine sometimes you do this kind of surgery without having to be able to map the tumor, map the brain. Again, these are challenging things. If you have learned that you can map the brain, but then you have patients that you cannot do that for. Again, patient comes in with deficits, perhaps from the fact that you do not know where the motor fibers are or certain fibers, and then you kind of know that what the outcome of the surgery would be. So again, I think if you start gradually, we started from outpatient craniotomy with awake without mapping, and now we have the privilege to be able to map some of these patients. Obviously, starting to be able to go into the cellar through the nose was also another thing that we had to build up. Obviously, most tumors in LMICs challenge the fact that they're not just big. Most are still by craniotomy, and then you ask yourself if 95% of pituitary tumors that are now almost changed as nomenclature as pituitary neuroendocrine tumors, and now access through the nose, why are we going to keep doing craniotomies for our tumors? So we decided to take the bulls by the horn. I'd like to dedicate this part of my talk and practice to a very great mentor and teacher, Professor Fred Gentili, who recently passed on from the same disease that he's lived his whole life fighting, which is GBM earlier this year. Obviously, you can see operating with him both micro, and he was one of the great inspirations for my endoscopy approach to the tumors. So basically, you find that large and giant pituitary neuroendocrine tumors do not form a large chunk of most series that we do find in the literature. Obviously, from the Toronto series, what you do have is that you find 73 of 487 tumors that they were exposed to were large and giant. And when you talk about large and giant, you basically are talking about tumors that are greater than 3 cm in their widest dimensions, or greater than 4 cm if you're going to label them as giant tumors. Obviously, if you look at the meta-analysis that was recently done, the question what I want you to pay some attention to is the number of patients. You could see that generally, people do have this low exposure to these giant tumors. And obviously, one of our very own great person from Asia, Atul Goel, has one of these high numbers from India. But obviously, their approach is more microscopic and not endoscopic. So I'm just trying to put it into perspective what you will face in LMICs. And so we decided to look at the initial 43 patients that we did, and we found out that 39 of them were actually large or giant tumors. I mean, their average age was 48.5 years, and the mean tumor diameter was 4.09 centimeter. Obviously, we do have more of the giant tumors. 76.9 of them were 4 cm or greater, which you could actually say is huge. But when you look at the numbers, as we try to push the frontiers without almost all of what usually we would need in terms of hemostasis, in terms of things like tissue glue that were not available, we decided we would continue to push the frontiers and see how far we can go. Obviously, when you look at the extent of tumor resection, it's pretty something that is comparable to what you would find in terms of when you put the near total and gross total tumors excisions together. And to have the visual outcomes improve in 69.2% of patients, obviously, is rewarding. But when you look at the complications, that's an issue, another place where there's a challenge, and you see mortality of 7.6%. And these patients really had meningitis, CSF leak, and obviously this was not from a surgical issue. There was no vascular injury, and that's a little challenging for us in terms of control. But we do find that in the last couple of patients, 10 patients perhaps, CSF leak is almost 0%. And so we're trying to optimize what we're doing. And I think it just tells us about the learning curve. But then you got to keep pushing. Obviously, one of those illustrative cases, just to let you know, that it doesn't matter what the social demographic strata that the patients are coming from. This is a nurse who had presented to us with the size of this tumor, but then he looked from treatment 2 years later, represented with the size of tumor that had almost doubled in size. And we had to do an endoscopic resection, and you could see a remarkable decompression of the optic chiasm. She recovered vision in one eye, and she has returned back to work. Again, the challenge is such that you must make yourself available. It doesn't matter whether you're practicing LMICs. We must commit ourselves to push the frontiers for the sake of our patients. Obviously, when you have a Jehovah's Witness man in front of you who is not willing to take blood or in any form in terms of intraoperatively, but you can obviously prepare them preoperatively, and now you're going to go endoscopic. You have challenges with your hemostatic agents not being available, but we still took it on. And obviously, we were kind of much lucky when you see that it has some cysts. The tumor had some cysts, suggesting that it was going to be soft. And so we did gross total tumor resection, and you can see where the pituitary is, the optic chiasm, as well as the stalk clearly delineated in the post-op scan. Again, I think some of the challenges is also the fact that you get conflicted when you know that big craniotomies are no longer what people will generally do. Again, it increases operating time. It kinds of, because of continuous exposure to anesthesia, you're challenged in trying to ask yourself, without neuronavigation, which is this kind of single most important thing that you use to plan for bone flaps, at least in neurosurgery. The question is, what do you then do? So you're first with a patient like this, a 61-year-old with metastasis, and it's not just metastasis in the brain, you know, he's got metastasis elsewhere. You want to reduce the time for surgery. They initially thought it was some hemorrhagic stroke, but then we found out that it was a hemorrhagic metastasis actually. And so we had to go after it. And obviously the scans don't show all of the story, but then if you look at these, you have to try to the sinus, superior sagittal sinus on the other side, and put your craniotomy flap just in between. And so we were able to do this without neuronavigation. The bone flap was just about 2 centimeters. I mean, this is a principle I actually learned from one of my mentors. I don't think that everyone, there's no real what you would call big ideology about small craniotomy, small bone flaps, but then it just saves time. It gives you access if you know how to target where the tumor is. And so using just craniometric points, we were able to get into the tumor, and you could see that it was gross total resection for the patient. Again, this was a patient with a left temporal GBM. Again, this is just all changing what the threats are in our own environment. The incision barely 5 centimeters, and then the bone flap itself just about 2 centimeters, 3 centimeters bone flaps, I beg your pardon, and then gross total tumor resection. Obviously, we're also oftentimes challenged with bigger tumors like this in LMICs. You don't have, sometimes you have to operate this kind of huge tumors with your surgical loops rather than with operating microscope. So again, I think the key there is also almost learning, having your competence really a top notch in order to be able to go after these. Let me change a little bit of gear from just surgical things, because one of the challenges that we have is how do you then characterize your tumors? Obviously, that challenge is enormous. Obviously, parts of India, and I think I'm not part of Pakistan now, can actually do molecular markers for their tumors in order to be able to reduce what is non-otherwise specified diagnosis of these tumors. And then we know that key to these is establishing a brain tumor bank. Obviously has all its advantages, but then again, you're faced with overcoming infrastructure challenges and dealing with logistics. So again, I'd like to show the slide to say that you can do it. Obviously, this is the -80 freezer, but when you look down here, it's a lot of batteries, because again, to keep these because of power issues was to completely from the beginning connect this to the solar system, solar panel system, such that you have 24 hours regular power without need for shifting from the national grid. So again, obviously, this is cost intensive. This is not what people in HICs would experience because they would have power 24/7. But in a number of LMICs, you'll be challenged, but then you have to go find a way around it. Again, I do not take for granted organized neuro-oncology in terms of pushing the frontiers forward in LMICs, and I cannot Animal's work and colleagues over there in terms of personal, and we also have started a while ago, we're almost 5 years now, Society for Neuro-Oncology Sub-Saharan Africa, and we continue to collaborate with colleagues all over the world as well as within the continent in order to push the care of these patients forward. Obviously, we had our own meeting in July this year in Ghana, and the next meeting, which I like to invite everyone to, is in Nairobi in 23. Obviously, you could also go for safari as a part of your holiday, and it's also going to be during a good weather time during July and August. So how do we consolidate? We think that establishing collaboration within and outside of the continent is key. And obviously, for my much younger colleagues, I think education in terms of short courses, fellowships, and observerships are key to actually developing a neuro-oncology service and continue to push the frontiers in terms of care for patients. I do think that LMICs do argue whether we should be subspecializing. I think we must go beyond general practice in whatever we do to subspecialization. I think the world has gone beyond just doing things because you're a neurosurgeon or because you're a radiation oncologist, just focusing on many things. I think we need to start focusing on particular things like neuro-oncology. Obviously, if we fail to adapt, we fail to move forward. So we got to use what we have to go towards where we want to go. If you can fly, then you got to run. If you cannot run, then you work. If you can work, then crawl. By whatever means, you just have to keep moving. Was the message Martin Luther King left with us. I want to thank you for your attention, and I appreciate you once again for the privilege. Thank you very much.
Thank you so much, Dr. Balogan. Thank you for this enlightening talk. And you talked about the neurological tumors in LMIC. Thank you again. Our next speaker is, we are heading towards our next presentation. So our next presenter is Dr. Shota Tanaka. He is a lecturer and Deputy Director of Education and Safety at the Department of Neurosurgery at the University of Tokyo. He specializes in genetic analysis of the brain tumors, molecular target treatment of malignant brain tumors, and neuroendoscopic surgery. Today, he will be presenting on glioblastoma treatment, standard treatments, and novel therapies. Welcome, Dr. Shota.
Thank you. Can you hear me well?
Yeah, clearly.
Okay. Thank you. Thank you for the kind introduction. And then I also appreciate your invitation to this wonderful meeting. Let me share my slide. So I heard that some of the audiences are nurses, medical staffs, and technicians and medical students. So I chose this topic as my talk. Can you see this slide?
Yes.
Whole screen. Hold on. Can you see it?
Yes.
Okay. So I chose this topic. So it's more like a webinar type of stuff. It's not cutting edge at all. So if you think that this topic is too familiar, you can actually skip my talk. Anyway, so let me move on to the talk. So here, glioblastoma, it's as all of you know, it's most common primary malignant brain tumor in adults, accounting for roughly half of the malignant CNS tumors. So its incidence is about 3 to 4 per 100,000 in the United States. Median age at onset is in the mid 60s. It's known to portend poor prognosis with an overall survival less than 2 years. When you look at the statistical report from CTBRS in the United States, it's very poor. It's very short because it includes all the patients, even the palliative patients. And then if you look at the statistics from Japan, it's pretty much like what I said, 15 months for registry and 20 some months for clinical trial patients. So when you think about the standard treatments, it's multidisciplinary in nature, including surgery, radiochemotherapy, followed by adjuvant chemotherapy. First step is the surgical treatment, obviously. What's the significance of surgical treatments for adults newly diagnosed GBM? This is the practical guideline of neuro-oncology in Japan. It says the greater extent of resection results in longer progression-free survival and overall survival, as long as performance status is good postoperatively. So here, there are numerous papers or studies look at the extent of resection and survival, and this, I think, this is one of the most famous or well-cited papers. UCSF group, Dr. Sanai and Berger. It says that extent of resection of 78% or greater leads to improved survival in patients. But more recently, this is the paper or the consensus review by Snow and Iano. It says only gross total resection is likely to be associated with improved outcome in both newly diagnosed and recurrent glioblastoma. Here are some evidences that are quoted in that paper. Of course, if you try to actually gross total resection, and then you have to be really aggressive in that. And then when you take too aggressive approach, and then you might injure the patients. And obviously the postoperative deficits, either language or motor, it adversely impact the patient survival. So for neurosurgeons, we have to weigh risk and benefits of surgery, aggressive resection. In order to achieve or decide how aggressive we should be or how to achieve safe maximal resection, we have adopted various types of surgical adjuncts. For preoperative evaluation, we use functional MRI, tractography, methionine PET. For tumor visualization, we use navigation, fluorescent probe like a 5LA, and intraoperative MRI. We have to preserve patients' neurocognitive function as much as possible. So we routinely use neurophysiological monitoring and also awake surgery if the tumor is located in the language area. When you think about the chemotherapy or the chemo agents, you have to look at the guidelines, how evidence-based one treatment is. So let me just introduce this NCCN guidelines from the United States. So obviously the temozolomide is the standard treatments for newly diagnosed glioblastoma. It's an oral alkylating agent. And based on this study by Stuparol, temozolomide concurrent to radiotherapy, followed by 6 cycles of adjuvant temozolomide, is superior to radiotherapy alone in overall survival. As for predictive biomarker, MGMT or O6-methylguanine DNA methyltransferase is the one. Temozolomide is efficacious for GBM with methylated MGMT promoter. So here's the flow to consider the treatments of choice for each patient. It's a bit complicated, so maybe this is the better in understanding. Basically, regardless of the MGMT status, 6 weeks of radiation, concurrent temozolomide followed by adjuvant 6 cycles of temozolomide plus minus NOVA TTF or tumor treating field is recommended. It's basically for patients aged 18 to 70 because the STOOP study actually included those patients. So what about the elderly patients? But basically, it depends on how good they are or how they are able to tolerate multimodality therapy. If they are deemed healthy relatively, and we consider the same treatment strategies, concurrent radiotherapy and temozolomide, and we can even consider a 6-week radiation. But in elderly patients, we know that abbreviated or hyperfractionated 40 gray in 15 fraction radiotherapy is pretty much equivalent to the conventional radiotherapy spanning for 6 weeks. So it's more convenient. But with combination of temozolomide, it's unclear whether or not hyperfractional radiotherapy plus temozolomide is rather better than radiotherapy alone. So this study on the right side was the one to answer the question. And for elderly patients as well, radiotherapy plus temozolomide was superior than radiotherapy alone. For bevacizumab, I don't know if it's totally country dependent. Actually, the bevacizumab is available for newly diagnosed glioblastoma in Japan. Probably Japan is the only country, maybe. In this practical guideline in Japan, it says that bevacizumab added on to STOOP protocol can be considered for adult newly diagnosed GBM. Bev is a humanized monoclonal antibody against VEGF, and it inhibits angiogenesis. It's an IV drug every 2 to 3 weeks. It's been approved for other various types of cancers. What are the evidences for newly diagnosed glioblastoma? These are the two Avaglio and RTOG-0825 trial, looking at the upfront BEV added on to STIP protocol. Interestingly, there are two. Well, they show that pretty much exactly the similar looking Kaplan-Meier curves, meaning the improved progression-free survival, but exactly the same in terms of the overall survival. What does it mean? It means that non-progression on imaging doesn't necessarily mean tumor control. And it's another thing is which is controversial is effect on patient quality of life. In Avaglio trial, quality of life or KPS are maintained longer with bevacizumab treatments, but in RTOG-0825, quality of life and neurocognitive function rather deteriorated in bevacizumab upfront treatment. So who are the subpopulations or the subset of patients who really benefit from upfront BEV for newly diagnosed GBM? Post-hoc analysis of Avaglio suggested that overall survival was longer in BEV arm when only patients not treated at the progression were analyzed. So maybe BEV add-on may be beneficial to patients who were anticipated to be very poor candidates for treatment at progression. There are several kinds of approved drugs for newly diagnosed glioblastoma. Calmustine wafer or Gliadel is one of them. In practical guideline in Japan, it says that calmustine wafer can be placed after resection of newly diagnosed glioblastoma with some recommendations. This is the paper introducing the results of from the randomized phase 3 trial exhibiting the survival benefit with the Gliadel wafer. But this wafer comes with some potential adverse events, some potentially serious, which include brain edema, wound dehiscence, and CSF leak, and so on. So each case, you have to decide whether or not it's really indicated. Another thing is Novo TTF 100A system or tumor treating field. It's Optune by Novocure. Novocure Optune added on to adjuvant chemotherapy after surgery and postoperative radiochemotherapy is considered with good evidence. This is a novel device that disrupts alignments of highly polarized tubulin subunits and also microtubule spindle formation. And then also it inhibits cell division, ultimately leading to apoptosis. So it's when you look at the NCCN guideline, it's also recommended as an alternative or the option to add on. EF14 trial is the study which reported remarkably good data. And interestingly, it stopped early given the survival benefit based on interim analysis. So in terms of the progression-free survival as well as overall survival, the hazard ratio was very good, 0.63 or something. And because of that, it's approved throughout the world. But of course, this device also comes with adverse events, including contact dermatitis. And there are some concerns for compliance and patient quality of life. What about the recurrent disease? For recurrent disease, preferred regimens include bevacizumab, temozolomide, lomustine, carmustine, PCV, or regorafenib. So basically anything. And then on top of that, you might consider re-radiation, including stereotactic radiosurgery, or of course, re-resection. So regarding the novel therapies, so over the past few decades, numerous molecular targeted agents have been invented and tested in the clinical trials throughout the world. But when you look at this government clinicaltrials.gov recently, only 22 phase 3 trials are running for glioblastoma, and then very few molecular targeted agents are there. But some other new agents that seem to be promising is obviously immune checkpoint inhibitors, and nivolumab is one of them. It's been approved for melanoma, non-small cell lung cancers, and so some other cancers. But for newly diagnosed glioblastoma or recurrent glioblastoma, it's been negative in clinical trials. It never shows the survival benefit on top of over standard treatments. But an interesting study was done for pembrolizumab, another drug of immune checkpoint inhibitor. This is the pilot randomized multi-center trial led by Ivy Foundation in the United States. Included 35 recurrent GBM patients randomly divided into preoperative pembrolizumab group versus postoperative pembrolizumab group. And survival curve clearly split, and then preoperative pembrolizumab group was better in overall survival. So what that means is that the preoperative treatment with anti-PD-1 antibody may enhance anti-tumor immune response. So maybe these drugs better be given preoperatively, or maybe in conjunction with other immunotherapy or other molecular targeted therapies or conventional chemotherapy. So as a Japanese neurosurgeon, neuro-oncologist, I have to actually mention this drug, tesirpatarib. This is now approved in Japan this year. This is the first viral therapy using the simple herpes simplex virus type 1. And it's genetically engineered with 3 mutations that led to the augmented and selective replication in cancer cells, and then also enhanced induction of anti-tumor immune response. So this drug agent was actually tested in a single center phase 2 single arm trial. It included only less than 20 patients. And the primary endpoint was 1 year survival rate. That was 84.2%. It's quite good, and which led to the conventional conditional approval. This was published this year in Nature Medicine. Again, that this is approved conditionally with a need for post-market study and also a plan for re-evaluation 7 years later. So indication is malignant glioma previously treated with radiotherapy and temozolomide. Dose is this, and that will be given up to 6 times with some intervals between these two surgeries. So it requires surgery each time. That's a main point. And despite this promising effect, and despite this publication, it's still tested in a single center and it's never been validated. So we have to do this in Japan to prove that this is going to be one of the good agents for newly diagnosed or recurrent glioblastomas. So in summary, safe maximum resection improves prognosis of newly diagnosed glioblastoma. So we have to try to maximize the resection while sparing or securing the safety. The STIP protocol, including radiotherapy and temozolomide, is entertained for newly diagnosed glioblastoma. Hyperfractionated radiotherapy is considered for elderly GBM patient. Nova TTF or Optune system can be added to adjuvant temozolomide after radiotherapy in selected cases. And Tesirapatirab has been approved in Japan as a first approved virotherapy for brain tumors. So thank you for your attention. That's the end of my talk, and then happy to take questions.
So thank you so much, Dr. Tanaka, for this wonderful talk. I thanks again all the presenters, Dr. Wu, Dr. Balogan, and Dr. Tanaka for taking out time and give us presentations. So we have a couple of questions from our audience. One of the question is for Dr. Balogan, and this question is from a medical student, Salar Ahmed. Salar wants to ask that capacity building with sub-Saharan region, how many neurosurgical residency and fellowship programs have been established in the region? Because if we keep relying on the trained neurosurgeons from abroad to serve, so LMIC has a population which is actually very high, along with the high disease burden. It's like putting a bandage on the bullet hole. What do you think? So,
okay, great question. If you can hear me, absolutely valid observation. And I think that for most sub-Saharan African, let me speak about Nigeria where I practice. With the slides that I showed you, obviously there has been remarkable increase in the number of neurosurgeons that are trained in the last decade. And so emphasis right now is on training centers. The training centers for training new trainees and making them neurosurgeons has actually increased over time. And so for us as a people, this really just, we really don't focus, like you said, on getting people in to do the work. We do the work, they're locally trained neurosurgeons, but then quite a lot more would also have subspecialty training, perhaps outside of the continent, and return back home. And so the focus is actually both on medical students kind of doing, getting into neurosurgical practice. And there's actually 1 or 2 studies that actually interacted with medical students to see what their perception is in terms of choosing neurosurgery as a career in order to be able to overcome and help them overcome those obstacles. Now, the second part of it is also the fact that aside from that, even the Neurosurgical Association within Nigeria now has a forum for young neurosurgeons that basically includes the trainees. So emphasis is on training, emphasis also on collaboration within and outside of the continents. And collaboration does not necessarily mean that people will come and operate for you, but then there can be a transference of skills, there can be interaction in terms of research, and there can be interaction in terms of organized societies like we do have here. I hope I have answered your question.
So thank you so much, Dr. Balogan. One question is for the Dr. Wu. One of the student want to ask that one potential utilization of your AI algorithm is that it can allow the greater sampling of the tissue. And currently the pathologist sample less than 1% of the total tumor for histologic diagnosis. Any data that greater sampling will improve the diagnosis outcome? Is this worth exploring?
Your question is about the neuropathologist's workflow will assist to evaluate the accuracy of the AI system.
Actually, the question is about that if we sample the greater tissue,
yeah.
would it help in your algorithm results in accuracy?
Yes. So now we use the whole slide scanner. So the whole slide scanner can take the images, cover the whole glass slide. So that can answer your question is more sample, especially the image. I mean the area of the image, more information will be got by the AI system, and the diagnosis accuracy will be improved then.
So which means that more the information we give to the system, the more accuracy we'll get,
Yes.
right? Yes.
Correct.
Thank you so much, Dr. Wu. So Dr. Altaf has a question and he wants to ask himself.
Thank you very much. I think all three talks were excellent, and I would like to ask one question from each speaker. So my first question is from Mark Balogan. Excellent talk, excellent service, and your enthusiasm to serve your own people and stay there is really appreciable. I was just wondering how, as a neurosurgeon, it's just particularly related to the field, how you manage the situation where you feel some kind of deficiency. For example, endoscopic surgeries, oftentimes I saw in Western countries, they have easy availability of surgery floor they can put in and the bleeding stops. But in our part of the world, it's always a challenge. How you cope with these difficulties when you came back from your fellowship? So this question is directed towards James Balogan.
All right. Okay. Thanks a lot. So pretty good question. Great question. And you would notice the fact that I said some of those things, and like you mentioned, are not available, and you have to just keep going. So, for example, when you start from the nasal part, and you're going towards the saliva and the tumor, there is something you need to control it. I think the basic principle of neurosurgery then jumps up at you. Just park it. And you park it for a while. It kind of wastes your time in a way, because it then prolongs your operating time. But then when you do that, most of the times the bleedings will stop, and then you can continue. The other thing is, whatever you have, sometimes using just straightforward Surgicel rather than using things like Flowcell would kind of work. So you just put some Surgicel, put some gel form, and whatever you're doing is going to, the bleeding is going to stop. The other thing about endoscopy that we couldn't do without was the fact that we had to get a Doppler ultrasound. So if you notice, there was no vascular injury because intraoperatively we needed to have a Doppler ultrasound to guide us so that we avoid the cavernous carotid as well as the supracavernous carotids. So in a way, I think the most important thing is that you have to have so much competence, or you have to be competent in what that procedure is and not just be exposed to just the normal nuances. So for me, in just concluding, apart from my clinical fellowship, once I know that I was going to kind of dive into endoscopy surgery, I had to also do a research fellowship in Pittsburgh, and I had to also go for continual courses. So that kind of gives you that edge to know how to adapt things. You may not have everything, but then you know when to adapt things. And I think the other thing is also case selection. You have to be very careful in how you select your cases. The other thing that we did with endoscopy was I made up my mind from the start not to go it alone as a neurosurgeon. So I had to get an ENT guy who was familiar with sinus surgery, but not necessarily skull-based surgery. And then we started together, and then we have built a team over time. And now we can do things without having to talk to each other, knowing fully well what the next motion is going to be.
Thank you very much, Dr. James. Very, very good answer. I just want to ask a question from Professor Wu. Hello, Professor Wu. This is
Yeah.
Salaf. I hope you
Hello.
remember me. So it was really an excellent talk about innovation in neurosurgery. I was just wondering, how about linking histopathological diagnosis to the radiological findings, and then developing some tool that can diagnose tumor based on both radiological findings and the histopathological findings? You develop a data for 1,000, for example, for 1,000 patients, and then give some artificial things to diagnose preoperatively to give a diagnosis to the neurosurgeon and to the patient as well. And the second part of my question is, do you think that the artificial intelligence can help the patient, or it's a just fanciful idea of a neurosurgeon?
Yes, I think your suggestion is excellent. So if we can link the medical records as well as the medical images together with the histological images, I suppose we will got the more accurate diagnosis for each cases. So that's a good suggestion. So what about your second question?
So this artificial intelligence, do you think that this will eventually benefit the patient, or
Yeah.
it's a just fanciful dream of a neurosurgeon?
I think the AI can benefit not only the patient, but also the physicians to release the workflow to ease the workflow of our daily work.
Right. So my last question is from Dr. Shota. Excellent talk, Dr. Shota. I was just wondering, when you were giving talk, that since 2005, when this STOOP protocol arrived, so far we haven't done anything substantial to improve the survival benefit of the patient. So where do you think that the panacea or the treatment of this glioblastoma lie in next 2 or 3 decades? Where would we go? Because viral therapy, tumor treating fields just give benefits of few weeks, just few weeks. I was listening to the talk of Stoop back in 2015 when he was vehemently advocating tumor treating field, but the survival benefit was just 4 weeks. So where do you think the treatment lies for this monster, mysterious monster, I would say, for humanity?
Yeah, thanks for your wonderful question. That's indeed, that's one of my greatest questions and greatest interests. I think, there's nothing one type fits all type of thing. So I don't think any single agent can treat the majority of glioblastoma patients. So I think, we need to go for like more like a precision oncology type of stuff. Of course, when you try to do this precision neuro-oncology and looking at the genetic profile, obviously there are several obstacles in glioblastoma, such as like intratumoral heterogeneity, CNS penetration of the agents, and so forth. But I think I'm doing that as well. I was actually a fellow about a decade ago in the United States, and MS General and Dana-Farber. But after a decade, now I'm, as a neuro-oncologist, neurosurgeon, I'm practicing oncology here in Japan, and then do some precision oncology type of stuff. And I see quite marvelous response with molecular target therapy, as long as it's right on target. So I think we need to figure out, like other cancers, we need to figure out which type of or which subset of glioblastomas are more prone to any specific agent, that kind of stuff. So if you find a couple of them, and in conclusion, and then I think we need to improve the prognosis of GBM, like a step by step.
It's Dr. Talha. I have got a question for Mr. Shota. So do you think that the same algorithm or regime of treatment, resection and temozolomide, and after that Novocare, stands true for low-grade gliomas? I mean, you had a talk for GBM.
Mm-hmm. Right. Not necessarily, because basically if you look at the biology, it's different. Like for example, but majority of the lower grade glioma is IDH mutant versus de novo glioblastoma is IDH wild type. So maybe the biology or the biological nature of the tumor might be different. So we might have to actually tailor some between GBM, like a de novo aggressive GBM versus kind of mutant, indolent, relatively indolent IDH mutant lower grade glioma. So basically, we have very few choices as a treatment options. Temozolomide, like Calmerstein wafer, Novo TTF, and bevacizumab, and all those things. So we have to, come up with the best solution or the best combination for lower grade gliomas. So, but that's that. So quite a slightly different approach should be taken for lower grade glioma, I think so.
Thank you very much. And a little question for Dr. James. In countries like your and in country like our as well, where it is not everywhere available. These gadgets are not everywhere available. Functional, MRI and perioperative mapping. Do you think that we should more emphasize in training of our residents on craniometric, landmarks and identification of, Salsai and Guy perioperatively for a safer resection of these tumors?
All right, thank you. I think the idea is to use what you have in order to be able to provide what is safe surgery for the patient. Using craniometric points is usually what we have all learned. Obviously, some folks from the HICs may have lost that in terms of the fact that they have navigation to play around with every single day. But then I think if you listen to all of the guys who were the superstars in neurosurgery, they tell you that basic anatomy is still key. So I think we still have that single advantage in LMICs where residents are actually exposed to basic anatomy. They got to do it because they don't have access to all of those gadgets. But the truth is, it's not like the gadgets are not necessary. Make your surgery safe. And at some point, you kind of localize lesions much more easily and you go after them and you keep the brain safer. In terms of mapping facilities, I think the issue is that it's basically difficult to kind of operate on tumors and eloquent regions without having to map the brain, but that's what we've done oftentimes. But the question is, we need to weigh that with respect to outcome and particularly in relation to the quality of life of the patients. Because if a patient is going to have, obviously from the studies that have been shown, the quality of life of a patient also will usually affect the overall survival, right? So if a patient already presents with a speech difficulty and then this speech difficulty gets worse after surgery, I think it's an issue for that patient. So in a way, we would continue to push, but we will not stop. It doesn't mean we should stop doing the surgeries because again, if you don't do them, the patient is going to die anyways. So you're going to have to weigh between what time you give to the patient, what quality of life you give to the patient, what's available to you. And like I said, we started, there was nothing like mapping, but eventually we got something out. So again, I think it's going to be a stepwise thing. For intraoperative guidance, for example, ultrasound is absolutely fantastic. And then it goes beyond the disadvantages of neuro navigation in terms of real time, like provision of your being able to localize things. So I think using low technologies like ultrasound, obviously we also know that there are high-end ultrasound that are way beyond the purchasing power of people in LMICs, because now there's there's navigated ultrasound, there's all kinds of stuff being infused into ultrasound, but we can stay with the basic ultrasound and still get some remarkable results. So I think it's focusing on the things that we have while we hope that we can get the things that should be standard of care, and we keep doing what we need to do.
So we have a last question for Dr. Tanaka. It was interesting to see the promising results of recent immunotherapy agents for glioblastoma, but the cost is really high. Is there any possibility to develop low-cost solution for LMIC?
Thank you for the question. So far, the yes is no. I don't know. Actually, this drug has been invented by one neurosurgeon from a single institution and never be tested in other institutions in Japan even. So I myself don't have any expertise or any kind of financial solutions or financial issues and those kind of things in mind. So we'll figure out in the next year or two. We'll hope that we come up with a better solutions for more cost effectiveness of our therapy in the future.
Okay, Dr. Tanaka, thank you.